Before we start this episode of the Nuclear Medicine and Molecular Medicine podcast, I'm in Vancouver. So I'm at the Society of Nuclear Medicine meeting and I'd love to catch up with you. So if you're at the meeting, please message me through the app or through the communications people at the Society of Nuclear Medicine, and we can catch up and perhaps do a podcast on some of what you're doing. So it'd be great to catch you here in Vancouver. Welcome to another episode of the Nuclear Medicine and Molecular Medicine podcast, and we're coming from the Australian New Zealand Society of Nuclear Medicine meeting in Brisbane. So it's good to have you back on the podcast. It's the world's longest running medical podcast, and I'm privileged to have one of the director of one of the greatest nuclear medicine facilities in the world that's been famous for many years, from Stanford, and it's Andrei Iagaru, and he's going to talk a bit about what he's presented at the meeting today. In particular, I thought your discussions about Bombesin complementing PET PSMA. But first, tell us a little bit about yourself. Tell us a little bit about where you work in particular. You've had some tragedies that's happened at your work recently, and that's affected the whole world. But you've had a great history of development there for decades, and some of the pioneers of nuclear medicine works occurred at Stanford.
Yes, thank you so much. It's an honor to be here with you for the podcast, but also for the Australian New Zealand Society of Nuclear Medicine meeting. We just heard about 30 years of PET this morning. Amazing storytelling and great contributions to the community worldwide. So thank you to the entire Australian New Zealand community for doing that. So I work in nuclear medicine at Stanford. As you said, we have a long history of luminary people that we try to emulate and continue their tradition. Started in the 40s. Contributors to development of endocrine nuclear medicine, cardiac nuclear medicine, oncological nuclear medicine. We are part of the journey with Professor Sam Gambier over the past decade plus, and of course his tragic passing a couple of years ago still impacts us. But although there will not be another Sam in our lifetime, we're all trying to do our best to continue his work. And not just his work, but also the spirit in which he did his work, which was a very collaborative, very open-minded, everything, we're all equals.
Yes.
We work together to advance the science.
Well, I think what was amazing, what's special about Stanford and a lot of the key institutions in the US is that they bring people from all over the world, who then either go back and contribute like they have in Australia and like they have in Europe, but also many of them stay on and make big contributions.
Right. We like to joke that it's United Nations at one institution.
It is
Maybe
absolutely.
one or two people were born in the US and everybody else is from some part of the world. And I think that this contributes to the growth of the field and also making it better, right? Because we have the opportunity to learn from each other.
Yes, absolutely. And part of that world of focus means that we've got an International Atomic Energy Agency, for example, that's promoting work in every single part of the world, from Bangladesh to Africa as well. So it's great to see that kind of work. Why don't you tell us a little bit about what you presented yesterday?
Don't bring coal to Newcastle, right? I mean, you did so much work in PSMA. I wanted to not emphasize any of our work in that field because really we just made it accessible to our patients. But what I wanted to show is that there's a great future for our field related to the therapies, but also outside of therapies in the space of oncology, in the space of cardiology, in the space of neuroscience. So I've shown some examples of new targets, whether there's labeled antibodies, whether there's brain metabolism, whether there's angiogenesis, other probes. But I focus most of my talk on the gastrin-lysine peptide receptor, also known as Bombesin, which is a pan-cancer target. It's expressed in prostate, but also in breast, ovarian, cervical, GI stromal tumors, and others.
And I think that's particularly important because it's not just prostate, but people think that cancer's a single cancer, or the prostate cancer is a single cancer, but quite often there's multiple cancers expressed in the same subject, right?
Right, and especially in a cancer where man survives on average 10 years, right?
Yes.
It'll be foolish to believe that the cancer at presentation is the same cancer at advanced stage.
Correct.
And so, there's nothing better than have multiple tools in our armamentarium of fighting this disease. And PSMA is great. We embraced it since 2015.
Yes.
We use it routinely. It's our second busiest practice after FDG, and it will only continue to grow. But it doesn't mean that there's nothing beyond PSMA, and I think that one of the things, together with amino acid imaging, is Bombesin.
Right, and so you found that it was very much complementary. It meant that often patients who had lesions, and they might have mixture of lesions. Some of the lesions would show up with the PSMA, and some would show up with the Bombesin, or they might be naive to the PSMA but still show up on the Bombesin, and that's implications for therapy. And for not just theragnostics as well, right?
Right. I think that, there's certainly overlap, same lesions seen on both.
Yes.
But there's also a number of patients where some lesions are better seen on one than on the other.
Yes.
And then you have patients for whom Bombesin is negative, PSMA is positive, or vice versa. And it's important for people to know that you will have patients with negative PSMA that can still be treated with a theragnostic sparer, but the theragnostics is not going to be PSMA, the theragnostics is going to be Bombesin.
Right. But also, if they've got a mixture, if they've got PSMA avid lesions and they've got Bombesin avid lesions, just treating the PSMA lesions is not necessarily going to have as good a result, is it?
Absolutely. And I would say, even if they show the same lesions, right, these are still drugs, right? They have adverse events.
Yes.
So what if you alternate cycles between one or the other?
Yes.
Right? That opens a whole new door where you have at least the same outcome, hopefully,
Yes.
but with less side effects, right?
Right.
Dry mouth is a terrible side effect.
Yes.
Right? Patients refuse to get treated. They want to enjoy their food,
Right.
enjoy their wine.
Yes.
Quality of life is so important for these
Yes.
patients. So maybe that's another area that we need to look at.
Right. I mean, I think it's important. But I guess one question you didn't look at yesterday, but I'd like to ask anyway, is where does FTG fit in the middle of this?
Right.
So if you've got lesions that are they're not that show up on FTG and not PSMA, or if you and then you've got Bombesin, could Bombesin replace FTG as a second agent in terms of working up and therapy, or do you also need FTG as well?
The straight answer is I don't know, because we have not done the study.
Right.
Intuitively, you would think that maybe that's the case.
Yeah.
But I would make the argument that if you get to an advanced stage where the cancer is less well differentiated, more aggressive, FDG positive,
Yeah.
why should the gastronecin peptide receptors continue to be expressed?
Yes.
So my intuition tells me that there's not going to be a huge overlap between FDG
Right.
and Bombesin.
Yes.
But let's hope someone will do the study. Maybe our group, maybe someone else.
Yeah.
It'll be a complex study, right? First, identifying what patient population,
Yes.
and then having them have 3 scans.
Yes.
Expensive, complex,
True.
but feasible.
But totally feasible. And remember, expense is relative. I mean, you looked at the difference in costs between PET scanning in Australia and the PET scanning in the US. It's maybe Australia should do it because the PET scan is a lot cheaper to be done here.
Although one would argue that in pure Medicare money, FDG PET is not that much more expensive in the US than in Australia.
That's true. That's true. And I think the other thing is that if you're pointing towards a therapies are way more expensive than any kind of diagnostic imaging, right? So you can justify spending money on I won't call it diagnostic imaging, I'll call it management imaging. If you can justify management imaging, even a high cost of management imaging is trivial compared to the cost of treating. And if you don't do that management imaging, you can get that treatment wrong.
Absolutely. Could not agree more.
Yeah. So, but also it's important that the nuclear medicine physician is involved in treatment. He's not just there to look at pictures, right?
Not only that, you're not there just to push the button, right? As I said yesterday, my colleagues who run the theragnostics clinic, and I want to mention my colleague Dr. Karina Marie and our nurse practitioner Kat and the entire team, we see these patients as if they would come to a med-onc visit, to a rad-onc visit. We see them in consultation. We have visits prior to each infusion. We order labs, we check labs, we treat them if they have adverse events from radiation. And we work very closely with our colleagues in oncology. This is a team sport, so we need to play it well together.
Yes,
for the benefit of the patients.
Yeah, and the lab tests are important because a lot of the things we're imaging for have biomarkers that express themselves in blood biomarkers, and that's often an early indication. And we've got PSMA, that's a blood biomarker, right?
Right.
So you've got to know how to do all that. You've got to deal with that, and you've also got, this is a radioactive material. You've got to have the expertise to deal with radioactive materials. So nuclear medicine is more than just imaging, right?
Absolutely, and also we're just scratching the surface, right? Even on PSMA, where we think we know a lot.
Yes.
There's still so much to learn.
Right.
All the post-therapy imaging, right?
Right.
What if after one cycle we can tell who's going to have a good response?
Right.
Just by data mining those SPECT-CT.
Exactly, and whether they've had enough results from that first to not need further treatment, right?
Exactly.
And again, that's those treatments.
Exactly.
Or that treatment's going to be futile. Again, that's those treatments.
It is very important.
So it's important that that kind of information we mine from what we're doing, and there's other ways of mining. I mean, part of that is to manage AI for perhaps looking at the images, but then you need an expert in understanding artifacts from AI, right? And because AI is wonderful, it can see in 3 dimensions, it can pick up 1% changes that can't be seen by the human eye. But what it doesn't do is it dumbly processes an image, and a smart physician can look at it and say, hey, there's something wrong here. And that's important too, isn't it?
It's a context.
Yes.
Right, and AI, jokingly, my initials are AI, so I should have licensed those for every time AI is used. But jokes aside, we need to embrace AI.
Absolutely.
Not be scared about it.
Yeah.
It will not replace us. It will replace those of us who don't embrace it.
Correct.
So like everything that's, revolutionary and a step forward, early adopters will try it.
Yes.
Majority will follow. Those who stay in their own comfort zone will have trouble.
Right.
So let's avoid staying in the comfort zone.
Exactly. I think we need to be uncomfortable in order to change, and we need to be excited about the new things.
Exactly.
And be prepared to get rid of the things that we used to do but aren't as good.
Oh, I totally agree.
Yeah. Talk about you. I didn't touch on the other things you think Bombesin might be useful for. Tell me, what do you think that might be useful for?
Well, so first of all, if we have resources, I would say from a suspected prostate cancer, when you need to guide biopsy,
Yes.
the biology should be interrogated. PSMA, Bombesin, perhaps other targets. And for the continuation of the disease status, you should follow with the biomarker that's best suited for the patient. Right? That's personalized medicine.
That's right.
In the end, right? Outside of prostate, estrogen receptor positive breast cancer.
Yes.
Sure, we have fluorescodiol that's approved for that indication, but it has no therapy version.
Yes.
So if you show that Bombesin is non-inferior to the FDA-approved FES, then you have a therapy version for it as well. Other rare diseases, perhaps GBM, there's data showing that Bombesin is overexpressed in GBM as well, right? GI stromal tumors, ovarian, cervical.
GBM is almost impossible to treat. I mean, it's very difficult, right? So that's an important one. Even if it helps a little bit, it's going to do better than the current standard of care, right?
Right. And I would say that, coming back a little bit to what I spoke about, imaging angiogenesis, why give Avastin, bevacizumab, blindly?
No.
Right? If there's no angiogenesis going on in the tumor, the drug is not going to work, yet we don't use imaging surrogates to select patients.
Yeah.
So there's a field we need to advocate more for what already exists in our armamentarium, and it's under or not at all utilized.
Well, again, it's about imaging not just for a treatment of a disease, but a management of patient outcome and making sure their life is better. And part of that is to look at the biological underlying, whether you're going to give them a treatment a non-theragnostic treatment that is going to, all it does is make them miserable.
Absolutely.
Yeah. So, anything else you'd like to add along what you've talked about yesterday or from your experiences here?
I just want to say how proud I am as a member of the nuclear medicine community of how innovative our community is.
Yes.
How little credit we get for
Yes.
all the advances of science. But I think that, with more and more preeminence, with more and more recognition of what we bring to the table, there will be more understanding of how critical nuclear medicine is for patient care.
Yeah.
And will expand beyond prostate cancer to other oncological applications, to more cardiac applications, to neurological applications. And I really think the next frontier is imaging infection, right?
Right.
It has been sought for decades as one of the holy grails.
We've had a bit of infection around the last few years, haven't we? And we know that nuclear medicine works particularly well in that area, right?
Yes, in a very unexpected way. But we need to go beyond white blood cell scans, beyond FDG. We need to target the pathophysiology of infection. And
right.
There's work that's being done at many centers, including ours. And that's probably one of the next frontiers too.
Right. And we've also talked about things that overlap along those areas. We talked about this before on the podcast. F minus imaging for imaging vulnerable plaque, for example, right? Where you're looking at the chemical characteristics of dealing with not just cardiac disease but other diseases that deal with inflammation and so on. So it's being a lot of diseases have underlying inflammation. A lot of diseases have underlying therapies. Perhaps you can, even for difficult to treat oncology situations, you might even use a theragnostic, right? There's been talk about using it for HIV, for example, right? So there's lots of ways that we can do things, but what's required is us willing to take that risk and have a bit of imagination and do those sorts of studies to do it properly.
And as we both said, feeling uncomfortable, it's okay.
Yeah. Excellent. All right. Thank you very much. Thanks so much for
being
being
my
part of
pleasure.
this. Yeah.
All right.
Thank you.
Congratulations on your